Yeah, thank you, Chad. So anyone joining, introduce yourself in the chat. We'll be using that for our question and answers as well. That way we can bombard Dr. Patel with as many questions as possible in the allotted time.
That's perfect. Hey, Vid, how are you, sir? It's a pleasure meeting you in person in Fort Lauderdale. Had great conversations with you. Thanks for being here this evening, as well as everybody else. I see there's Leslie Monroe as well from Dallas. Nice.
Got a Texas person in there. Nice.
Yeah, it's up your alley, isn't it?
It is. It is. Can't tell by my accent though, so
I'm only hear a baked potato and a piece of steak in front of you, then you can tell.
absolutely. Absolutely. Have a couple more
Hey,
joining.
how are you? Ushma's my neighbor actually, and I've not yet made the effort to go see her. She's literally one exit down from me.
You,
I'll meet her elsewhere, but in my own backyard. What's wrong with
yeah,
this?
that's the hardest part, right? The closest ones.
Yeah.
Ooh, Dr. Javed from Dallas, another Texas one. We're in trouble. You're gonna get flooded.
Yeah. Bring them on.
Got about 2 more minutes and I'll kind of start with everything.
Hey, Les, we need to get a school reunion going, dear. Leslie is the one that orchestrates everything for us. She's like our school mom. And taking this in parentheses, in quotations, actually, sorry.
Gotta have one.
Yeah, someone that takes the responsibility. She's amazing. Haven't seen
Absolutely. The ultimate cat herder. You need somebody responsible for that.
her. Mina from Michigan.
Michigan. Nice.
I think Anju said she was going to join us from Michigan as well.
Fantastic.
Hi.
More joining. Those of you joining, make sure to say hello in the chat and we'll use that for our questions and answers. And that way we can respond because I know Dr. Patel's going to have some good content today that we're going to have tons of questions for. Wallow Bay, California. All right. All over today. Michigan, Dallas.
We got Jeff Sullivan as well.
Yeah, that guy, our sales rep. He should be here, right, Jeff?
I had a good
Hello.
time with him in Boston when we were up there a month or so ago.
Yeah, that was perfect weather too. Sacramento. All right. All right, we got a couple people coming in. I'll give it another minute or two and we'll get this started.
Okay.
See, it's starting to increase, which is good. There's Jeff. Hey, Jeff. Oh, Western North Carolina. Nice. Me Myers.
Western North Carolina. Amy, are you close to Asheville or oh
Black
my God,
Mountain.
Black Mountain? You gotta be kidding me. My parents lived there till last year. They've been there for 17 years on the main strip.
Small world.
So small. I used to go there every month for the last 17.
White White Plains, New York. Got another San Diego, Florida. She works at Anders Dental. You probably drive by this place.
Yeah, man. The
All
Bush
right.
was my favorite place to go eat at. In Black Mountain. It's a South African restaurant. Mike is the owner. If you go see him, if he's still around. All
That's
right, go
fun.
ahead, Eric. Let you take it.
All right. Yeah, we'll go ahead and get started. I wanted to thank everyone. Good afternoon, good evening, everybody, and welcome to the True Function Monthly webinar series. We appreciate you taking your time out of your day to join us for this. And our goal with these sessions is simple. It's to share like real world working knowledge. Every month, we try to cover everything from digital workflows and clinical techniques to communication tips and patient management and even business strategy sometimes. So it's all centered around helping you treat patients better and run your practices with more confidence and more knowledge. So whether it's something new that we've learned or Dr. Patel's going to be presenting today that he's learned or something that you're interested in, please let us know and then we can build this out over the next few months. But use that question and answer section there to respond and ask those questions. And as we figure there's another topic here that we could build out, that could be another webinar for us. So let's go ahead and get started with that. True Function. So, for those of you joining us for the first time, welcome. Anyone that's returning, it's great to have you join us again. We're really glad to have you. True Function is a medical device manufacturer based in San Diego, California, specializing in sleep apnea and TMJ devices. But really, what we do is really far beyond that. For 25 years now, Frank started this 25 years ago. We're on our 26th year, and it's existed to make life easier for clinicians and for patients. And that's what we do every day here. We manufacture devices that represent, all the things that we want, which is tried and true, delivering consistent quality, friendly and personalized. We treat every doctor as a partner and being loyal and intentional because we stand behind our work and what our word is. So over the years, we've grown into more than a lab and become more of this community that you're a part of today. So thank you all for joining this. And through our webinars, educational programs, day-to-day collaborations, you can visit our education site and our resources page on our website. But we've built a space where clinicians and technicians work together to push patient care forward. So we're here to be a partner, whether that's with our devices or through our education or through our great speakers like Dr. Patel, who I'll introduce in a second. We're here to make that better for you and for us. So thank you all for joining this evening, and I really appreciate you being here. So without further ado, it's my pleasure to introduce Dr. Mayoor Patel. Today's topic is going to be the adjunctive therapies for oral appliance therapy. Dr. Patel, this is not going to be the greatest intro, Dr. Patel, but listen, you're a nationally respected leader in dental sleep medicine and oral facial pain, known for blending deep clinical expertise with a gift for teaching. He's a graduate of the University of Tennessee College of Dentistry, where he's also completed his AEGD residency and later earned his Master's of Science degree from Tufts University. Among his many distinctions, Dr. Patel is one of the only and handful of dental professionals in Georgia, board certified in dental sleep medicine, and he's one of just 2 practitioners in the nation to hold a triple board certification in craniofacial pain, oral facial pain, and dental sleep medicine. So today he's going to bring that experience and clarity to clinicians. He really wants to help all of you around the country to elevate patient care through a deeper understanding of pain, sleep, and airway health. So please help me and join me in welcoming Dr. Mayoor Patel. Thank you so much, Dr. Patel.
Thanks, Eric. Appreciate it. Thank you all for even taking the time out on a Tuesday evening to jump onto this webinar. I know it's recorded. You can always come back and view it, but sometimes it's just good to be in person so you can ask any burning questions you may have. And of course, thank you to True Function to allow this type of a platform to allow education to be passed freely and get people interested, collaborate, and get your sparks lit up so that you can be providing care for your patients as well. So what I'm going to talk about is adjunctive therapy. Adjunctive therapy is such a touchy subject. We either feel comfortable with it or we don't feel comfortable with it. My goal today is to kind of show you that there's just not one thing that we can offer our patients. We need to also be mindful that other things may have to be done in conjunction to oral appliance therapy to get better outcomes. But I'm going to start with just some foundational work and then just add to it. The first is when it comes to appliances, we all start from ground level. We have a patient, we need to do something for them. We're going to pick a device. The most important thing, of course, is titratability. And the biggest debate and discussion in our profession, and it's probably more opinion driven, some experience driven, and some literature driven, is which way do we go? Do we give patients more protrusion to try and improve airway, or do we give them more vertical? And I'll be frank, there's no right answer here. A lot of this will be case by case, a lot of it will be patient by patient, but I do want you to see what the literature kind of supports. Now, if we look at vertical titratability, you'll find both methods, some excessive vertical versus some protrusion, will give you better outcomes. However, if you ask the patient what would they rather prefer, the vast majority would want less vertical. The comfort might be to create a decent lip seal so they're not mouth breathing and therefore have dry mouth and things like this that might negate further outcome, compliance with appliance therapy. But if you need to also understand a few basic principles. When you give someone vertical and you don't put the protrusion component with it, you run the risk of actually compromising the airway. And this this velopharyngeal study done, look at the velopharynx, shows that about 80% of the time you're going to get an adverse response with just vertical. How I want you to take this, independently of a sleep appliance, is when you're putting TMD splints as well. If a patient is vulnerable to having an airway issue and we just stick vertical without a protrusive component to it, we could potentially make the airway actually worse. In some instances, you could have a positive effect, but the percentage is so low. And in some instances, almost close to 20%, there's no difference that occurs. But we need to be mindful that vertical, for more times than not, could be a little bit counterproductive. There was an amazing study done looking at what actually happens to us when we sleep. I think we can all agree that when we go to sleep, we become atonic. A result of atonia is lack of elevated muscle support. So if there's no muscle support, you're going to have this phenomenon called jaw drape. So what these researchers did, using some magnets and some sensors, they're trying to measure how much does the mouth open. And they looked at healthy subjects versus those that actually had apnea. And what they found that there's a progressive increase in vertical as the stages of sleep would increase. So in other words, when you go from stage one all the way to REM, the state of atonia actually increases. As you know, REM sleeping the most atonic in nature. So as a response to it, you'll see some level of jaw drape that happens, such as a separation between the upper and lower teeth. Well, what they found was it was more positional related. So if you're on your back, the jaw drape was much more pronounced as opposed to if you're on your side, but more open during sleep in patients obstructive sleep apnea. So apneics, there's a high propensity for this jaw drape to be excessive. The other way to maybe look at this, is it possible that excessive jaw draping leads to apnea? And these are questionable, debatable questions that could be asked. And if you think about this for a minute, when you open the mouth, you get a rotation that occurs, and the rotation posterializes the tongue, which is very detrimental when it comes to people with vulnerable airways. So when you look at healthy subjects, there's a certain range you would drape, right? Between 0 and 5 millimeters. But when you look at apneics, is much excessive, and some instances even greater than 10 millimeters, suggesting that, holding someone in a vertical position, even though we're trying to improve the airway, could probably be counterproductive because the opening that actually occurs does compromise the airway. So studies have shown that protrusion is probably the better way to go. And if you look at better outcomes, then protrusive would probably be the first line of approach. Secondly, superior treatments have been shown with minimum bite opening. Now, we have to understand from a manufacturing standpoint, there's certain thicknesses that are required for devices to be durable. And this is information that you can retrieve from the laboratories. But with the newer materials like acetal and so forth, we can kind of get away with not having to have too much vertical. However, with acrylic type devices, we're looking for a minimum at least 4 millimeters, the most posterior molar. So controlling the vertical component can also be indirectly done by material choice of the device you decide to use. Now, in dentistry, we don't sometimes think things through. What I mean by that is we fit a device, we monitor a patient for a period of time, and if we don't get the outcomes we want, we may blame the device and go manufacture a different one. The problem you run into at the end of the day, no matter what device you use, it's all about taking the lower jaw forward, right? So if you protrude the mandible against the maxilla, it really doesn't matter how we do it. Yes, maybe thickness may play a role, but at the end of the day, it's one device or one arch up against the other. So if you look at comparative studies, and there's a bunch of comparative studies out there. For instance, if you look at this one here, which is a tap and like a Herbst type device, and say, okay, if we were to put these devices in patients, which one will give us superior outcomes? Well, it turns out from an apnea-hypopnea index, there's no statistical difference with it. Even with the Epworth Sleepiness Scale and so forth, all the means that would use to verify what sleep felt like for the individual, there's no substantial difference between both types of devices, right? What it may come down to from would be a patient comfort, but probably more importantly, operator bias. Whatever we feel comfortable with monitoring, advancing, using, maybe the cost associated with the type of device we choose would be the variables why we would be more biased towards an appliance. If you look at this, a herps, which is quite commonly used, versus a monoblock, which is not titratable, and if you hold these two positions the same and monitor them in patients, say, okay, what gives you better outcomes? Turns out in this comparative study as well, there's no substantial difference between the two. They may have been more preference from a patient standpoint, but outcome-wise, you got the same metric outcomes. If you look at this right here, which is a twin block type device against a herps, once again, quite readily used. Yeah, you might see from a short-term standpoint versus the long-term standpoint some of the complications, side effects with the herbs versus a twin block. But ultimately, if you look at the metrics associated with sleep, there's no statistical difference between one or the other. Right? Ultimately suggesting that if we don't get the appropriate outcomes with the device, maybe we're missing something else. It's not the device we need to blame. And we need to be fair. We may have a non-responder to our appliances that we need to take into consideration. So our goal is if these problems arise, what do we do? We're not talking about making another device, right? That's not the answer here. We need to understand. So let's just go through some of the more common things you might come across. Well, the first might purely be, is it possible that this person that you have here has more supine apnea, which is basically on their back, the apnea is twice as much than baseline apnea. Now, if that's the case and supine is a variable, then maybe we need to educate the patient and consider body positional therapy along with the oral appliance to try and get better outcomes. All right, so if it's at least twice um, the value of apnea on their back, we call this then supine dependent apnea. All right. So what can we do? Well, a couple of things is what patient population is more likely to be these? It's the younger, those that have less severe symptoms, and those, of course, less obese are more likely to be positional patients. And if you look at it from a CPAP standpoint, which we can then extrapolate into oral appliances, you need more pressure when someone's on the back to keep the airway open. Well, logic might dictate then with an oral appliance, we may need to be more aggressive with protrusion in patients on that primarily sleep on their back, which might explain why sometimes the limitations, the device, and the tolerance to the patient's ability to have a very protruded position. All right. So look at your studies and look at the supine versus non-supine. And as you can see here, global AHI is 14.9. On the back, it's almost twice at 25.2. If you look at the data set and you kind of break it down on the upper right corner, you'll see that supine roughly had an AHR of 29.2. However, on the left side was 5.4. This is an easy case to treat with an oral appliance as long as we get the patient stay on this side, right? So we may adjunct supine therapy. But when you look at your raw data, you can kind of see this. So if you look at the line that says supine and you look at the clusters or where the apneic events are occurring, you'll see it corresponds with when the person's on their back, right? Which is kind of a giveaway. So when you start seeing raw data as such, the hypnogram, and you start seeing this type of presentation, you can then extrapolate that most of the events that are occurring with the device in place are primarily when the person's on the back. So for that, we may suggest some form of sleep positional therapy. And there's so many tools out there that one could utilize. And these are just to give you an example of a few. Like sleep noodles, something that's pretty new, but I found this on the far right of Amazon, interesting enough, where patients can sleep on their belly. Now, think about this for a minute. If on your back you worse, if you're on your belly, the jaw moves forward anyway, the tongue comes forward. I just don't know if someone can pull an entire night with it, but there is a product for those that prefer to sleep on their belly. The beautiful thing about this product, I suppose, is the fact that your head does not have to rotate 90 degrees to get air. So it's probably even easier on your neck. But there's also this thing called night shift. The problem with the night shift, it vibrates, and as a result, it may wake you up. That vibration of waking you up can also disrupt your sleep, right? So if you can just have something physical that prevents you from falling on your back for the most night, uh, might be much more easy to utilize than something that will actually vibrate that might awaken you, but of course gives you a cue to kind of flip. Your bed partner can do a good job just rolling you over as well. The second might be what were nasal issues? Maybe nasal issues are playing a big role in addition to the oral appliance, where we kind of discounted the nose, stuck the oral device because they got a diagnosis without the understanding that their nose may not be working effectively. Now, if you look at the Starling resistance model, basically what it states is what you have upstream, if you have less resistance upstream, you're not going to have as much turbulence as the air passes through the area where the soft tissue is not accompanied by any bone enclosure. So when you look at the upstream aspect, what we look at is the nasal passage. So the last part of the maxilla or the posterior nasal spine, just before it folds over, from that point to the first tracheal ring, everything is pliable, movable, which means any turbulence in any direction will cause some form of negative resistance that will lead to collapsibility, therefore increase apneic events, all right? Now, if you look at the nose for a minute, you look at some of the studies associated with it, turns out nasal surgery in some patients that have apnea actually reduces AHI and upper sleeping score in those that nose or the nose is playing a role. Improves subjective symptoms of ESS and AHI, decreased CPAP pressure because the nasal passages are much wider, easier air to be blown through. Significant AHI and excessive sleepiness reductions purely by looking at a meta-analysis. And you get a sense that by getting the nose to work, we can improve not just compliance, but also adherence to therapy. And the same should be extrapolated when we look at oral appliance therapy, because even though we're not physically blowing air, nose is going to be part of the big equation if the person's nasal breathing. And if the nasal passages are constricted for whatever apparent reason, we're going to get negative resistance as pointed out by the Starling resistance model. And therefore, in that movable, collapsible tissue, even though there's an oral appliance pulling the jaw forward and therefore the tongue base forward, it may not be enough. Right? And there's some amazing studies looking at this from a different perspective. Here they show that nasal obstruction causes a significant increase in the number of apneas during sleep, right? Purely from the nose. Nasal congestion in periods when someone has upper respiratory also predisposes the person during that time period for having a sleep disorder breathing. But take this into consideration. You already have an apnea that has nasal congestion that's not been managed. It's going to make the airway worse. And some of the most common reasons for it is basically rhinitis. It could be allergic rhinitis, it could be acute seasonal, infectious. The list kind of goes on, which means we need to loop in our ENT colleagues. But you also have things like septal defects, nasal polyps, concha bullosa that may be playing a role here. And any of these elements is going to affect nasal airflow passage. And this is where an ENT needs to step up, scope, see if there's any specific reason to explain why the nose may not be working as well, and then of course manage it. But when you look at the literature at large, it turns out that deviated septums followed by terminates will probably be some of the most common reasons for it. And if we look at some other reasons in the general population, roughly 12% of the US population deal with nasal allergies. And when you look at chronicity, about 15% of the US population deal with some form of chronic sinusitis. But anatomically, about 80% have a deviated septum, not always requiring surgery, but something that definitely needs to be assessed. In addition to that, also terminal hypertrophy needs to be considered. There again, nasal sprays, nasal steroids, things of the sort may help shrink the tissue. But if we have a full bony reason for it, then surgical intervention may be necessary. I think to really get the power of the nose, this next study kind of demonstrates this. What these guys did is took 12 healthy subjects and basically on baseline studies on them. And if you look at the results, so nasal breathing, sealed mouth, the AHL is 1.5. However, oral breathing by sealing the nose, the apnea hypopnea index on average went up to 43 events per hour amongst these 12 individuals, suggesting that if you can't use the nose and you're purely using your mouth to breathe, it's going to make you just as vulnerable to actually have apnea. All right, so this I think is pretty powerful to illustrate the point that the nose needs to work. But other things about the nose can be just things as far as the nasal valve collapse, which you can observe when you look at your patients. Look at the opening. Is the nasal valve symmetrical in nature or does it look collapsed? As you can see in the second picture in. And the third picture in, you can see that the patient's left nasal valve is completely collapsed. Now, there's this thing called a caudal test that can be done chairside to determine whether some form of artificial device that can be inserted to open up the nasal valve may help. And we do this to most of our sleep patients when we figure out that maybe nasal breathing may be a hindrance here. The caudal test is basically you take your hands, place it on the lateral aspect of your nasal passage, and just give a little tension in this direction, and have them close their lips And inhale and exhale through the nose. And we have them do about 5 breaths, and then we have them do 5 breaths without doing it. And say, which method did you prefer? The little traction, was that easier for you to breathe, or just breathing naturally? And if they suggest that the little traction actually helped with airflow, then we suggest things like nose cones, nose aids, and there's a whole bunch of other products like mute and so forth to keep the nasal valves open. So in this example right here, you can see the picture on the left, the right nasal valve, a little bit more compromised than the left. But when you put these nose cones in, you can see how it just opens up that lumen. The best way to extrapolate this information is this. On the left, think of the nasal passage as being coffee stirrers. And it takes a lot of effort to suck fluid off a coffee stirrer. So that being said, if the coffee stirrer is turned into a slurpy straw, as the picture on the right, it's much easy for you to pull fluid up a slurpy straw. Hence, therefore, in this case, it's very easy for you to draw air in without significant nasal resistance, therefore not creating negative esophageal pressure, which leads to more collapsible tissue. All right, so something just as simple as this in conjunction with oral appliance is not a bad fit. Another alternative could be breathe right strips, right? Just put some breathe right strips, and once again, you get that springiness effect from the breathe right strips, which is supposed to encourage improvement of your nasal valve. I have one patient that not only does nose cones, but does breathe right strips, and the combination works for her. So everybody's different, but you're going to have to try things out to see what may be more conducive. The other thing that might be important at this point in juncture may be that the fact that they can use their nose, but for whatever apparent reason, they have a tendency of breathing through their mouth. In this case, mouth taping is not a bad fit. All right, oral appliance goes in, a small piece of tape right here, midline can be incorporated and encouraging nasal breathing. Once again, creating a seal to just encourage more nasal breathing. Things to keep the nasal passages clear, all the way from a neti pot to simple nasal sprays to simple saline rinses, or all the way to this product called Xlear, which I do put a lot of my patients on. Just helps the nasal passage from having a membrane on it so that allergens can't stick to it. And if the allergen does not stick to the mucosa, then you don't get an inflammatory response, and henceforth you don't get any inflammatory process leading to shortening or constricting of the lumen. So things like this can be simple aids that one could incorporate. Now that Nasonex and of course Flonase is over the counter, at times we may do a short run of nasal steroids to try and shrink that tissue to see if we get better outcomes with oral appliances and making sure the nasal valves work. And some patients may be resistant to pharmaceuticals. Well, in that case, we may suggest using peppermint oil. Problem with peppermint oil, it works short term. In other words, the first few hours of sleep, it helps. But as the night progresses, the peppermint oil washes away in the sense that you don't have that strong pungent smell, and therefore you lose the vasoconstriction effect that peppermint oil has on the nasal passages. If you recommend peppermint oil, the best way to do is you take an earbud, saturate, you sniff it a number of times, and lightly, provided they don't have a cold or where they've used a lot of tissue to cause abrasions, put a little bit of a lining on the inside of the nasal valve on both sides. And the idea is when they inhale that air, that oil, it actually leads to vasoconstriction, helping to keep the lumen open. So once again, there are things as such that one could utilize. Mouth breathing, as we talked about, taping can definitely be a factor. But another thing with mouth breathing could be the appliance itself. Could it be that excessive vertical was mistakenly chosen for whatever reason? And because there's too much vertical, they have a hard time getting a seal. And this is where appliance choice comes into play. All right, products like acetal can help. Because once again, you don't need as much thickness for durability. And we can get away with much thinner products. The intention with using something like acetal, once again, is to drop the vertical, allowing a better lip seal so that the person is not mouth breathing. Now, in few instances, you might have where the person has a tendency with the device being mouth, the mouth props open, all right? Not that they don't have a problem with nose breathing, but the fact that the jaw is being protruded when they go through the stages of being atonic, there's a little bit of a jaw draping that occurs that kind of pries them open a little bit. That leads then to mouth breathing. Vertical elastics of some sort can be added with ball clasp or some mechanism of action to try and create some form of traction to keep the two arches interposed, right? So just adding elastics to help with keep them together would not be a bad thing. Now, we always are going to deal with large tongues. I mean, that's half the reason why these patients have what they have. But now we have a dilemma. We've fitted an oral appliance, we've tried to titrate this device as best as we can, but yet we're not able to get results that are achievable. So in some cases, conjunction therapy with some form of surgical intervention may be necessary. I think a tongue reduction might be too radical, but still an option. But something like the somnoplasty, which is basically a good way to kind of cause some tongue shrinkage along with wearing the oral appliance, would not be a bad idea. We use a procedure called VOT here in Atlanta called ventral only ablation therapy. The German actually developed the technique and so forth. He's a very dear friend of mine. I will use him. And what he'll do for me is shrink the tongue, but instead of coming from a dorsal approach, he actually comes from a ventral approach. The advantage of the ventral approach is the tissue shrinks in the direction of heat. Dorsal kind of makes sense, but kind of if you think it through, may not work as well because if you're going from the occlusal surface, right, the dorsal aspect into the soft palate, the way the burn is in the direction of the heat, so the tissue shrinks more superiorly. However, the tongue is turning. If you go ventrally and you create a burn, then the anterior wall of the airway, which is the posterior part of the tongue, shrinks anteriorly to keep the airway open. So once again, it's just a matter of technique, but this is definitely a viable option that can be utilized in some instances. Now, there's this as well called Excite OSA. Presently, it's prescribed by physicians, but I want you to be aware of this product. It's a neuromuscular electrical stimulator that these individuals wear for about 15 minutes, typically once a day, and then kind of you draw it out, use an app to control it, and you just bite into it. And it's got electrodes that basically affect the flow of your mouth and the junior glosses as well. And the idea here is to establish the muscular tone. By getting some muscular tone, it's been shown in their research to help with outcomes pertaining to obstructive sleep apnea. I think this is a poor man's way of doing myofunctional therapy. Those that don't want to commit, they just bite into this thing here and let the electrical stimulation do it for you. But we know that myofunctional therapy in some instances can help reduce apnea scores, right? So once again, we think of adjunctive therapy, a large tongue, flaccid tongue, jaws taken forward, some level of improvement when you do a post-op study with your oral appliance, but you still can't turn that page. This is where you may want to think about using a myofunctional therapist because as mentioned, there's improvements that can actually happen with AHA reductions. And there's been a handful of studies to demonstrate. I'd say most of the studies have been more towards pediatric, but yet it can be extrapolated that there's a few adult studies to show that you can get some level of reduction using myofunctional therapy. So just something there again to keep in the back of your mind to try and help with improvements of outcomes. Now, what about excessive salivation? They say this is a side effect when you look at the literature, but I think it's just an effect that happens because the person's wearing a device that maybe they've not worn, maybe the size of the device as compared to a mouth guard or Invisalign, but this is all short-lived. So one of the most common approaches with excessive salivation is to have these patients wear the device probably 30 minutes before they go to bed. And the idea for that is to start desensitizing. I used to in the past, encourage patients to do this for a period of at least week to 2 weeks. And if still salivation was a problem, then to consider taking Benadryl. The advantage of Benadryl will dry you up a little bit, and as a response to it, you might get some better outcomes. But there are other medications that one can utilize. Do understand that medications definitely have some side effects, and there are some conditions that you don't want to use it when someone has like glaucoma or prostate hypertrophy and things of that sort. So we got to be mindful where and when we prescribe some of these medications to reduce salivary flow. But we know salivation happens with other forms of therapy as well, like CPAP therapy and so forth. So it's not just oral appliances, but there is a short adaptation period when it comes to salivation and not really a negative effect associated with it. But I've only had one or two patients completely outright refuse to use oral appliances because of the fact they were drooling excessively. I will give you one caveat that if the person has a tendency of drooling a lot initially, make sure they put some Vaseline on the corners of their lips when they use the oral appliance, only for you to minimize actinic cheilitis from actually happening, which does happen with a lot of saliva. So just keep that in the back of your mind. Other things we may want to consider are things like smoking, right? So we know smoking leads to upper airway edema. So the patient's a smoker, having a heart-to-heart conversation about maybe changing some of the smoking behavior would not be a bad thing. I want to share this. I just picked this picture up about 10 days ago when I was flying to Malaysia and Doha at the duty free. I was walking by and I saw these signs, and it's pretty obvious the ones on the left. Smoking kills, smoking kills, smoking kills, got it. One on the right caught my attention. Smoking may reduce the blood flow and cause impotence. Wow. even putting a statement as such, you still got people smoking. It's a hard sell that even by labeling it, people are still buying cigarettes. But that really got my attention there to try and get people to quit smoking. But let's look at smoking for a minute. So smokers have about a 2 to 3 times high odds ratio of actually getting obstructive sleep apnea. And this is purely on the merit of edema that actually occurs because of the smoke. Right? So smokers by themselves are already going to be at high risk for being apneics. Chronic mucosal inflammation, edema, and increased collapsibility of the pharynx has been shown to be a result of smoking. You also, as a response to it, interested in get a high nasal resistance, similar to all the things we talked about the nose, where your nose now gets compromised to the point that you change the size of the lumen, increasing nasal resistance purely on smoking. More sleep fragmentation occurs and lower sleep efficiency occurs in smokers, right? Now, here's where it gets interesting. If a person stops smoking, you can actually get a reverse of the edema. It can take between 1 to 3 months. There's been some other animal studies to demonstrate it can be up to 4 months. So you don't want to draw the conclusion when the person stops smoking and they're wearing an oral appliance. I'd wait probably 3 to 4 months and then repeat the test to see is there any further improvement. Not a matter of you got a follow-up study, you still have residual apnea, you have this heart-to-heart conversation to stop smoking. Wait about 3 to 4 months and then get a follow-up study done and see was there significant improvement in it. All right, former smokers showed reduced risk of OSA. So once again, if they stop smoking and stay off of it, the risk of obstructive sleep apnea also reduces. And some cases, CPAP tolerance actually improved in those that were smokers. So once again, having that conversation about smoking and its effect on the edema, mucosal inflammation, along with nasal resistance, is just as critical as any other discussion you might have. Alcohol, as we know, is a suppressant, right? It suppresses muscle tone. As a result, it's going to create more dilation of the pharyngeal muscles, and this doesn't help. So these are common patients that have a glass of whiskey at night, or beer at night, or wine at night. We got to kind of take this into consideration and educate them the fact that alcohol could be working against us, even though we have an oral appliance in there. Most important probably is the spectrum of weight gain. I mean, at the end of the day, most apneics, for the most part, are overweight. And if we can reduce the weight, we can improve the outcomes, right? And what this shows is if you have a 10 to 20% drop in body weight, you have about a 2 hours per event change in mean change of apneic events, suggesting that a significant weight loss is important. I won't go through this slide, but I want to explain something to you. The GLP-1s that are now on the market has shown to improve apnea scores. Everybody's jumping on this GLP-1 bandwagon, which is fine. There's definitely time and place for it. But the fact that they are showing that you can get significant reduction in AHIs by using such. I also crop this in for one reason only. This is a good way to kind of use as a cheat sheet, kind of etched to memory. When a person says, how much weight do I need to lose and how much improvement will I get? On average, a 10% loss in weight will drop your AHI score by about 26%. However, a 10% gain in weight increases your AHI by 32%. All right. So putting weight one is very detrimental. Losing weight helps, but not the same rate as what you see when you put weight on. So you got to lose a lot of weight to get improvements when it comes to your apnea score, but still something to have a discussion with. The other thing might be like combination therapy or dual therapy. So if you look at this gentleman right here, he was on CPAP, was non-compliant because the pressure setting, which is about a 14 centimeters of water, he opted to come in for oral appliance. As you can see, he's a severe apneic, 46.8 times per hour. His main complaint was snoring, pauses of breath, difficulty to concentrate, and some memory impairment. All right. Put in the device, we titrate it as best as we can. We do another follow-up study. This is also in-lab study, and you'll see that it goes from 46.8 to 21.5. So we look at success rate with severe apneics, you're looking for a 50% or greater reduction. However, numerically, we got the numbers. However, symptomatically, he's still tired, he's still not able to concentrate, and he's still snoring some. Right? So we kept on titrating him, but he couldn't tolerate the titration. Vertical, he was not interested in because he already had a difficult time getting a lip seal with this device, which was fair. So we then had to have a face-to-face discussion and say, what's the option of you, or what's the possibility of you returning back to CPAP along with the oral appliance? And that's ultimately what happened. We did what we call dual or combination therapy. Here's the beautiful thing. With both these two forms of intervention, his CPAP pressure now is roughly about 9 centimeters in water. He has zero events and zero complaints as far as his symptomatic symptoms he had. But remember, his original CPAP pressure setting was about 14 centimeters water. At 14, he couldn't tolerate the mask on. At 9, extremely bearable, extremely tolerable. He could tolerate the pressure with the oral plants in play. But what happens is when you take the jaw forward and you bring the tongue forward with it, a lot of the extra pressure that's required to blow past the obstruction is not necessary. And as a response to it, the pressure setting can be dialed down, making these patients very, very compliant. And you can see that combination therapy can be one of anything. Any type of face mask, any type of oral device. You put the two together, we call that combination therapy. And there's been studies to look at combination therapy showing that with combination therapy, you can drop pressure settings and also apnea scores, right? So there's some benefit in combination therapy. Now, I've not done this for any personally, but I want to kind of just put this out there. There are instances where patients have gotten Inspire done, and with Inspire, they're still asymptomatic. Okay, you dial up the settings in Inspire, but because of the electrical stimulation, is now causing cortical arousals, which is now disrupting the sleep. The disruption in the sleep is not helping. So what's supposed to help the airway, which is helping with Inspire, the electrical stimulation now is disrupting your sleep. So we kind of back to the beginning. There's one case study in the Journal of Dental Sleep Medicine showing combination therapy of using a stimulator along with an oral appliance. The advantage here is when the oral appliance is in your mouth, you have the ability to bring the jaw forward and most of the tongue forward. And now when the stimulator goes off, it's just a nice subtle impulse to keep the tongue forward. This is all spanking new. It's through the FDA. It's in the FDA right now, but will be being launched pretty soon. This might replace Inspire. The reason I say that, there's no wire that needs to be fished. It is a one surgical procedure where this implantable device called the implantable stimulator has to be embedded in the tongue. But what powers it and what drives it is on the exterior. So this little patch is added just underneath the chin, and you can use your app to control the power and the intensity. But the principle is almost similar to the hypoglossal nerve stimulator. It's a new product that will be coming out to market soon. But when you look at it from dentistry standpoint, we all have toys, we may have lasers, and this may also need to be taken into consideration where we now have the ability to maybe shrink some of that tissue using a laser. Night laser is the one I'm showing here as the picture, but I'm sure there's other manufacturers that have similar outcomes with their lasers. And there's some articles, interesting enough, on their website that have now been published to show the correlation and connection of laser therapy and its effect on the soft tissues and therefore the improvement in your apnea scores. Now, I know this is a lot, and I know this is something that you may not hopefully come and be dealing with, but I need you to know that there's a lot more tools out there when it comes to adjunctive therapy. I don't want you to hang your hat that it's device only. It's device addition to a lot of other variables. If I say one of the giveaways here, make sure you account for the nose. If anything, the nose is probably going to be his biggest failing grace when it comes to oral appliance therapy. Patients need to be able to breathe through the nostrils. Well, I'm happy to say that this was nice, sweet, and short, and comfortable, and of course, right to the point, as pointed out by Eric. But I'm happy to take any specific questions you may have, whether it's a case you've been dealing with or you have any other recommendations that you want to talk about. Great question. I see there's why not MOPI? Why not tongue reduction surgery instead of tongue reduction surgery? I suppose MOPI could be done, but if you're going to do MOPI, you have to abandon oral appliance therapy, right? So then it's almost like you're saying, oral appliance therapy is not working for you. Go get some MOPI done, go get some expansion done, see how much residual apnea you have, and then maybe return back for oral appliance. My whole talk was leaning more towards the fact that they have the device and we're trying to see what else can we do to improve the outcomes. So just keep in the back of your mind. But to your point, orthognathic surgery could be something that could be discussed in this space. But then these are complete failed therapies, right? In the sense that you've done all your due diligence, you can't get the outcomes you so desire. And in that instance, I totally agree. You got to look at other forms of intervention. So let's post some questions that you might have in the webinar chat. Yes, and thank you very much, Salman, for the angular cheilitis. Yes, that's exactly what that is. And unfortunately, it does happen with people with excessive salivation. So I may even suggest if it's a new device, just first week or two, just go and coat Vaseline on your lips as you wear this device, just so you can get through the adaptation period. And if there's no salivation or any of those negative effects, then you can, abandon that. The funny thing with Vaseline, interesting enough, is it sticks, right? It's sticky. And you'll find patients that say, I used to tape, but now that you told me to put Vaseline, my lips stay together because of the stickiness of Vaseline. So, I mean, in a way, I'm not saying it's a lip taper, but it could indirectly, for some patients, serve as such because of the stickiness nature associated with Vaseline. All right, people, any questions that we might have that we can help answer? If we move forward, the appliance, don't they disturb the occlusion? Yeah, they do disturb the occlusion, but this is the risk you got to take, right? And do you understand when you're doing oral appliance therapy, occlusion is definitely something you want to take into consideration. However, you can negate the negativity of oral appliance therapy by giving them the appropriate tools. One good tool is just bite tabs that can be utilized to reset their bite the next morning. You don't get a change in tooth position up to post 5 years or more, but you can get a change in bite that'll throw your occlusion off. But that is totally reversible if the patient is compliant in doing the activities the next morning. True Function sells bite tabs that I actually get mine from. They also have a morning aligner that you can fabricate to verify that the bite has not changed, all of which you can get from True Function Dental Laboratories. Q&A. Okay, sorry. So let me go through a few more questions here. Can you talk us through the steps for ordering, prescribing oral appliance? How do you choose which device is better? Oh my God. Yes, I can. Okay. So the steps involved. I'm going to make some assumptions here. Forgive me. So I'm just going to make some assumptions to just make sure that we kind of all on the same page. If you've not done a course or some form of formal education, it's very hard to kind of explain the entire process. But the way this whole thing works is you go ahead and determine the fact that the person has apnea. You've had this conversation about negativity that's associated with oral appliance therapy, the big one being bite change, but you explain to them how you can change it, right? Taking a protrusive bite is one of the most important things. As mentioned a second ago, we don't want to just take vertical. Okay, taking vertical can negate what we're trying to achieve. You want to take a protrusive bite, and there's many methods of taking a protrusive bite, so I won't go over it. It's whatever you feel comfortable with. When it comes to choosing an appliance, frankly, I say choose what works best in your hands, but also check with insurance. Where I'm going with that, in the state of Georgia, for instance, Blue Cross Blue Shield United Healthcare requires me to use a PDAC approved appliance for any of the clients that had that insurance. So at that point, I have no choice but to go to PDAC approved device, right? Whereas everybody else, if it's free fall, then it's a matter of whether you like the dorsals, the mill devices, the EMAs, the herps, and the list goes on. And this probably will come right down to a personal preference. Now, I do digital scans, which is fine. You send the scans off to the lab, but I also get my digital bite. And the way I do my digital bite is if I'm using an apparatus called like a George gauge, for instance, I use the gauge to figure out how much protrusion I want to get. And I kind of just hold the jaw there by putting some bite registration material in the front. And then just scanning the side so that I have a protrusive position for this device to be manufactured. But the most important part is, besides giving the device, is giving the patients tools to allow them to get their bite back the next morning. Right? So bite change does happen, but I'm not saying be afraid of it because you never heard of anybody die from malocclusion as cause of death. But you probably heard of people dying in their sleep because they have arrhythmias or cardiac events occurs. And people can function with a bad bite. If you've done dentistry long enough, you've probably seen the fact that people come into your practice with bad bites and don't have any complaints. They find a way to chew, they find a way to do what needs to be done. All right, so I wouldn't be afraid of it, but I would take all the precautions necessary to try and minimize that from happening. And True Function has all the things you're possibly going to need to mitigate that. Let's see here. What else do we have? How long should you wear the device for a bite change to happen? This is personal. But I've got patients as old as 13 years that don't have a bite change, and I have patients as long as probably 3 or 4 weeks and they have a slight change in bite. The difference between the two is a person that's got it for the longest period of time with no bite change is probably doing what they should be doing every day. The device gets replaced every 3 to 5 years because the limitation of some of the acrylic devices, when the resin starts distending with time because of the forces of the jaw falling back up against the maxilla, you might get a tooth movement, and it does happen. So what we try and do to mitigate that, a new device 3 to 5 years. All right, so that's that problem. But the reason for the change is non-compliance. Patients not following through, not biting hard enough, not coming for their follow-ups. and then you catch it at some point down the road. Now you can reverse some of it, but not always can you get the entire occlusion back. So just, plant those seeds and emphasize the importance of the morning bite exercises to mitigate that.
Excellent. I'd go with Megan Keel, Dr. Patel. I'm just starting to consider treating sleep in my practice. Where would you recommend to start in terms of furthering my education?
Yeah. So this Sunday, if you go to Concord Seminars, I'm doing a 6 hour from 10 till 4 Eastern time that you can hop onto as maybe a feeder or get some information to get you started. And then I'm going to suggest you look for a 2-day course or some form of a mini residency course that has some hands-on component. Check with True Function. They are very kind sponsors of programs that we offer. So if you stay on True Function's mailing list, you'll be contacted with courses that might be coming up in the early 2016, mid 26 time period.
Absolutely. I think the next two, Dr. Patel, we can kind of combine into one. So, how do these devices or appliances, even with less vertical dimension, affect TMJ long term? And then do CBT show TMJ resorption with long term use? If yes, how does one prevent this?
So the answer is first question is vertical. So, from your standpoint, how much vertical do you need for acetyl to be durable?
Be durable? I mean, we're looking for maybe, I'd say I'd be comfortable saying a millimeter on each arch, so two total.
Okay, so that's amazing vertical drop, right? So from the old days of 4 millimeters being minimum threshold for acrylic, you can take that by half, which makes a difference.
Absolutely.
CBCTs, yes, you could take a look at the health of the condyles prior to treatment, but frankly, you remember these devices are only being worn for 6 to 8 hours. They're not in the mouth long periods of time to cause any form of condylar changes. If you had like a Herbst rod in a pediatric patient or a growing adolescent that you keep in the jaw forward because of growth and development reasons, you can get remodeling of the joints, but that's not what's going to happen with oral appliances. So I would not be worried about the joints. As long as there's no pre-issues with the joints, there should be no post-issues with the joints. So I wouldn't be concerned with it.
Excellent. I'm going to add back to your thinnest material. I think from a true function standpoint is we're flexible. I've done where I've done like a little mesial tab on the third molar just to get that vertical down, and sometimes we'll reduce coverage if needed. So it's something where it's a case by case or patient by patient basis. I know that Dr. Patel's great. We have some other customers that they'll be very clear in their instructions, or if we have concerns, we'll definitely give you a call about that vertical.
Yeah, and from your standpoint, as far as all the people that are on the webinar, use the lab's resources. I mean, they have seen so many cases come through, and they can be very creative. And to Eric's point, they can be very creative in the design phase. But communicate with the lab because that's where you're probably going to learn more from. And I get a lot of my pearls from the labs because they do so many cases that each case is a learning experience for them. So, tap into their resources for sure.
Absolutely. Absolutely. Any other questions? I got the Q&A open and in the open chat. Anyone have anything else that maybe we didn't answer?
Oh, nice.
They're still typing, I bet. You're saying,
That's fine.
there we go. Oh, thank you so
Oh,
much.
thank
No,
you.
thank you, Megan Kill. Amy Myers, thank you so much.
Yeah, Amy, if you do nothing Sunday, or Megan Kill, if you do nothing Sunday, just look at Concord Seminars. I know that's coming up soon, and then there should be stuff in next year for sure. I think as we get close to the end of the year, we all just done. We're out of gas.
Absolutely. Absolutely.
Yeah. Can you repeat why every 3 to 5? This is an interesting question, Ryan. So what we've seen is when you have patients that have got a device that's older than 5 years, you'll find that the day of delivery, the teeth were in a certain position. 5 years or later, they come in, the teeth are flaring. Typically, you get lingual version of the upper and you get flaring of the lower. But you also get teeth that move with their contacts open, but the appliance still fits. So it's not that the tooth moved the device, it's the device failed moving the tooth gradually over time. So with acrylic type devices, I just plant the seed 3 to 5 years. Now, what's also interesting is health payers will pay for a replacement in the 3 to 5 window. So, it's not like it's going to be an out-of-pocket expense if they have benefits for it. So we just prep our patients. Listen, this is not a lifetime device. These are the reasons why, but every 3 to 5 years, it's time for a new one. And the key is you take a look at the appliance when they come in. If you start seeing stresses or you start seeing spaces opening up in teeth, it's time for a new one. Lori, I mean, there's no right or wrong, my dear. I'm not bashing the school of thought as far as vertical. I'm just wanting you to think it through. With whatever I've presented up to this point, it is possible that okay, with pharyngometry, you do have a tendency of seeing more vertical, but that doesn't mean that it doesn't work for the individual. What you're trying to do is it possible with the vertical that you have, lip seal becomes a problem? Is it possible that you have the fact that you may have to protrude a little bit more to offset that difference that may occur because of the vertical? And we don't have anything directly to compare one from the other. But if we follow the science and you look at it from a patient comfort standpoint, if we're trying to create a lip seal, then we want to not take vertical in consideration. We want to be as nominal when it comes to vertical from a comfort standpoint, but more importantly, to get a good lip seal so they can use their nostrils. Okay, cool. Yeah, a lot of pearls, people. This is all we do is pearls, pearls, pearls. I think that's the only way to learn. The rest you can read or you can, all that good stuff. But, what true functions philosophy is, you go right to the nuts and bolts of things and how do things work and what can we do to optimize outcomes.
Absolutely. And I think I just messaged Chad, but you definitely can go to our website under the accounts or under the education webpage. You can find us on our YouTube. We've actually unlocked all of our past webinars. They're there for you to view and many, many Dr. Patel webinars. So feel free to, start an account. That's how you can get your bite tabs or morning aligners. And then with that resource page, there's tons of webinars. I think there's 20 something plus. I think 3 or 4 of them for you, Dr. Patel. Just how to choose a device from even the adjunctive therapies like today. So definitely make sure we register and check out the next month's webinar, while also reviewing some of the past ones that Dr. Patel and some other great speakers have had. Next month, our webinar will be on December 9th on 2025, and it'll be with Dr. Alan Blanton on incorporating TMD and oral facial pain into your sleep practice. So make sure you join that one. That'll be a good one. That's a big one from us this year. I've been hearing more and more about this combination of TMJ, TMD, and sleep medicine being the way to go. So I really think that'll be a good one, and I hope to see you guys there. So, any other questions before we go? I don't want to waste any more time. I think Dr. Patel's ready. If anyone's got one more.
Will C email to us directly? I don't believe there's any C for this.
Yeah, no CE for this one. These are just free webinars, more for information, and like I said, more the networking and building that educational center for everybody. Great present, very educational monitoring with apps. Is it worth it, Dr. Patel?
Yeah, that's a great one. So with the problem with apps you run into, it's a one channel, right? For example, I use Snore app a lot just to get feedback. But if you're using the app like Snore Lab to see if the person's snoring or not, always make sure that the person's in the room by themselves. And we've had so many situations where we think the appliance is where it needs to be. The patient's feeling great, but they come in and say, here's the recording. And it turns out to be the dog, or it turns out to be the bed partner, even though they think the bed partner doesn't snore. So you can use apps, but the best way is to use type 3 testing and just get a test done where you have more than one channel to determine outcomes. But yeah, using apps to screen like for snoring, I'm all for it.
Excellent, excellent.
All right, guys. Well, listen, have a great evening. Thank you all for being here. Thanks, Eric, for making this happen.
No, thank you. That was fantastic. You always make me think it's always more than just the device. What else can we do? So I appreciate that so much. I actually wrote down that we need to start selling breath strips on our website too, because it's there. It's needed.
Might as well, man. That, nose cones, if you want to get that, lip taping.
Yeah, no, I wrote all that down. Breathaway strips, because the bite tabs are there. So it'd be nice if we had like a little kit for each patient. Bite tabs, mouth tape, and that way they can try how. And
Yeah.
then I feel if they try one and they communicate back to you, hey, this is working. Hey, this isn't. They're already helping with that therapy.
You know what? You're on point.
I love it. I love it. Well, thank you all so much. Thank you for joining. I know on the East Coast it's getting late, so thank you all. Dr. Patel, again, thank you so much. It's always great to have you. Glad to be here, and let's do it again.
Yeah, no worries, man. You guys take care. Thank you. Have a good
So,
evening.
thank you, everybody. Have a good night. Bye bye.